Hi, this is Dr. Krishna Deepak, and welcome to another episode of Steth and Sip, short for Stethoscope and Sip. In this podcast, we bring you very unique insights into the field of medicine. This is a podcast by a doctor, talking to a doctor for doctors. So, today we have a very industry specialist. We have an IVF specialist, a highly experienced young doctor from Delhi, that is Dr. Bhavana Mittal. So, before I introduce Dr. Bhavana Mittal, IVF is picking up a lot in our country today. Even though we are the most populous country in the world, still there are a lot of infertility cases which are coming up. So, let us understand from Dr. Bhavana Mittal why this is happening. So, Dr. Bhavana Mittal, thank you very much for coming to this podcast. So, tell us more about yourself. Tell us why you choose this field. What made you come into gynecology, IVF, infertility? So, little bit about yourself.
So, first of all, thanks a lot for your very kind introduction. So, I started my journey in 2002 when I joined gynecology. I started my journey in Lady Hardinge Medical College where I did my post graduation. So, as you do your post graduation, you'd see different type of gynecological cases, which also includes infertility cases. Now, somehow, as I was doing my post graduation, I developed an interest towards infertility, especially because what I saw that apart from being medically suffering, these women were also suffering socially. So as you can understand, in India, with the kind of mindset our usually people have, these women are suffering socially as well. So if I thought that I could help them in any way, if I could gain some expertise and work in this field more. Also this field involves a bit of technological advancement, so that also intrigued me, and I wanted to learn more, practice more, and that's how I proceeded into infertility practice. So thereon I did my fellowship in reproductive medicine. So it is a recognized course under DNB, which I did from Ruby Hall Clinic in Pune. So that was a recognized center. My teacher, Dr. Sunita Tanulvadkar, she's a stalwart. She's currently the Foxy president. I trained under her. And Ruby Hall Clinic, as you know, it's one of the best centers in all over India. And so I got to learn a lot there, apart from the technological thing, otherwise also clinical practice, how to handle patients, how to deal with people. A lot of things I learned during my fellowship, which I completed in 2010. And that was when I moved to Delhi and I started my infertility practice here.
Wonderful.
Yeah.
So, one thing I think I should add to ma'am's introduction is that ma'am is a teacher. She trains young gynecologists in the field of infertility, which is a great service. And ma'am also is the director of Shivam Maternity Hospital, a very prominent hospital in Delhi, where they do this cutting edge therapies for infertile couples. So, ma'am, we are seeing a lot of scams
Yes.
in infertility.
Right.
So tell me something interesting about what is the scam that a couple has faced and they, in desperation or after multiple failure, they came to you. Uh, tell us something, an interesting case.
See, basically, like when I started my practice, that time there was no regulation of IVF in India, so every kind of practice was happening, There was no regulation, each one was left to his own, anybody could do anything. There was a lot of malpractice also going on. Now, given that only now the government has stepped into this and, the government has put up the law in place into 2021, and now a lot of things are streamlined, which is good because when we are doing some treatment like infertility and IVF, which is so close to the heart and the family, everything has to be transparent. And it should be clear cut, transparent with the patient. The patient should not be cheated or nothing wrong should be done at any point of time. Like, for example, recently only, like just while we were discussing, there was a case in Hyderabad, a
Yes.
couple, they went for surrogacy.
And that was a very prominent infertility center.
Yeah.
And we entire Hyderabad Doctors Society was shocked.
Yeah. So nowadays it is rare to hear such cases after the law. But previously, these things were happening, So somewhere from under the tables, we were hearing that these kind of things were happening where actually surrogacy was not being done. Or if surrogacy was done, it was not that IVF was being done. They were just conducting an IUI on the woman. So that is also actually malpractice, because
Yes, definitely, because the genetic material
is her. So you cannot use two things from the same woman, because it is
Yes.
her baby then.
Yes.
So I think these things, but as you say that in every field, there are people who are doing the right practice, there are people who are doing the wrong practice. Maybe the wrong practitioners are 5%, 95%. Still, as doctors, everybody wants to do good work, ethical work only. So, but yes, here and there you hear some interesting stuff, but it's a shame to our profession, I say.
Yeah. True. Excellent.
Because then to convince the next patient who comes, they have everything in their mind that okay, what will happen to us.
True. Wonderful. So, what I wanted to ask you was, see, infertile couples, they come to you.
Right.
And they come to you, first time they are coming to as a, they have tried normally for maybe 5 years after they got married. Or maybe they have visited different centers and did not find any success.
Right.
So, these kind of patients will come to you. So, how do you evaluate infertility in a woman? And what do you do for infertility in man? How do you evaluate them both?
Right.
What are the basic things that you do, if you can elaborate?
Yes, sir. So, sir, if we start going like by definition, so infertility is defined when any one couple has been having unprotected intercourse and has not conceived for 1 year.
1 year.
But this is not like the definition will always remain. If suppose the woman is more than 40 years of age, then you will not wait for 1 year. Or if in some case you know a clear-cut problem that, okay, she has an absent uterus, then you will not wait for 1 year. But by definition, for normal couples, if they've tried for 1 year and they're not conceiving, they are, by definition, having the problem of infertility. This problem, you can say, affects around 10 to 15% of the general population.
Okay.
Whenever such a couple is walking in, we as infertility doctors are treating the couple. So we are treating the man as well as the woman.
Yes.
So there are 4 compartments to evaluate.
Okay.
The uterine factor, the tubal factor, the ovarian factor, and the male partner.
Okay.
So if in the first go, there are some, of course, it starts with basic history taking, because 90% of the solution you can find there, a good history taking and a clinical examination. I think the age-old practice and the conventional things always stand. After that, it comes the role of investigations. So just to, investigate these 4 compartments, we try to do basic test. Always we have to remember that an infertile couple is already emotionally disturbed,
Absolutely.
financially challenged if they've already gone to some other centers. Like sitting in Delhi, many a times I am seeing patients who have already visited many centers and done, many investigations, and they already have a big file in hand.
Absolutely.
So my first job is to go through whatever is already done and pick things from there. Whatever is missing, only those investigations we like to do. It's always better to individualize rather than have the same blanket investigations for everyone. So for the uterus, a good transvaginal ultrasound works well. For tubes, we need to do a tube test, which can be either a hysterosalpingography, or these days we prefer to do a sonosalpingography. Okay. Then to evaluate the ovarian compartment, apart from the transvaginal ultrasound, we need some basic hormonal test. And for the male partner, a good history taking and a good semen analysis works well. So initially, this much investigation gives you a fair idea that where the problem is lying. Okay. So the first step is to take the history, understand their problem, do a good examination, and evaluate these 4 basic compartments by these basic tests.
I'm interested to know about this ultrasound of the tubes. How do you do that? I mean, is it an invasive procedure, or it is just normal ultrasound only? Because the tubes can be collapsed, right?
Right. Yeah.
So, or the anatomy will not be visible.
Exactly.
So, how do you do this? Because I have not seen this procedure very regularly.
Actually, it's a very basic procedure, but it's a very good procedure. I'm a big fan of this procedure. Earlier, like when we were doing our post-graduation, we used to do a hysterosalpingography.
Yeah, that
was an X-ray based test. Mainly the thing was, it is it's a very traumatic test.
Very painful.
If you do it without anesthesia, it's very painful to the patient. And mostly patients have a lot of phobia for a tube test,
Yes.
So now for that, this SSG, sonosalpingography, has come in, which is more sensitive, more specific, and you can say much, much less painful than a hysterosalpingography.
Okay.
So as you said, a normal tube cannot be seen on ultrasound unless there's a contrast in the tube.
Yes.
So to create contrast, we instill saline.
Okay.
So that is put in. So basically, it's a small procedure. It's an office procedure. You do not admit the patient for this. The patient does not need to undergo anesthesia for this. They walk into the clinic. We give them some basic like painkiller injections and all. We prepare them. Then in a good sterile environment in the OT, the procedure is done. And we have like fine catheters, specific catheters for sonosalpingography, or sometimes we can even use pediatric Foley's catheter, which and they are instilled into the uterus, and that saline contrast is pushed in.
Okay.
So the movement of the contrast can be picked up on a transvaginal scan.
Okay.
So you can see the fluid
It
going.
is more like actively when the saline is flowing.
So you
can
yes,
look
and
at
if
it.
you can add some air bubbles to it, so air creates hyperechoic shadows, and that adds to the contrast, and
Wonderful.
visibility increases. And it is a very like you can say 30 seconds to 1 minute procedure. Usually people with normal pain tolerance can get it done very easily. They can rest in the clinic for 15-20 minutes, get their report hand in hand there, and they can walk out after 30 minutes with the result.
Nice. This is something that I did not know.
Okay.
And that is what actually, even I was confused then, without any kind of medium, how can you do ultrasound? Because the whole thing collapses. So,
Yeah, so
you explained very well.
Yeah.
You take a saline and you
Yeah.
put it through a catheter. Very nice. So, one thing, what is it in Delhi and NCR areas? First thing is, what is the regulatory authority to actually monitor? Is there any regulatory authority which is monitoring infertility clinics? And second part is in Delhi NCR area, because that is where you have a lot of cases coming from, or around Haryana or Punjab or what do you call Uttar UP. So what is the most common infertility cause in women?
Okay. So I think after 2021, the system is same all over the country. So you have under the ART law of 2021, you have a central board regulating infertility practice, and then you have state-wise board. So similarly, we also have state-wise board of Delhi, which is under the ART bill, which is under the government. And also these days, infertility practice, IVF practice is under PNDT. So you have the PNDT law also, which governs us right now. That is regarding the sex detection part.
Yes.
So these are the two boards. So we have all applied to the board. We have got our centers inspections done, and we are still waiting for the formal registration certificates to arrive. But our inspection and everything.
So there
has
is
been
a
done.
process.
There's a process. There's a process.
And there is some registration number which is given.
Yes. And there's a level of clinics also, like level 1 clinic, level 2 clinic. They're very clearly defined at what should be the facilities, what kind of doctors should be available, what are the procedures could be done in a level 1 clinic and a level 2 clinic. If you want to do surrogacy practice, the license is completely different. You have to apply separately for a surrogacy license.
Okay.
So that's how you apply to the board. You fulfill their requirements. They come for inspection. If they feel that you have the appropriate everything, then they give you the certification.
Okay.
So that's the process, and that is what everybody is following right now regarding the regulatory part.
So level 1 is above level 2, or level 2 is above level 1?
No. Level 1 is lower. Level 2 is higher.
Yes.
Yeah.
Okay. So level 2 can handle surrogacy, embryo transfers, and
So level 1 IVF, level 1, level 2 infertility.
Okay.
Surrogacy is totally separate. So surrogacy is a separate license.
Okay.
Level 2 clinic can do IVF.
Okay.
And up in level 1 clinic, you can do basic stimulation of patient, follicular monitorings, counselings, all this can be done in.
So there is a strict regulatory case. And what about my second question that as what do you see is the most important or most common cause of infertility in this region?
So I think the division is same as we consider for the whole population. For example, we divide infertility causes into 4. So we say 40% of the cases it's the male partner, 40% of the cases it's female partner, 40%, 10% it is both partners, and in 10% it remains idiopathic. You don't know what is the
Unrecognized.
cause. So that is how it is. These days, however, over time, as we are practicing, something that we are seeing is that sperm count is declining. Rate of having people with lower sperm counts, lower motilities is increasing.
True.
Also, poor ovarian reserve, decreased ovarian reserve, these cases are also increasing. So that's what some observation over last 15-20 years that I'm seeing these patients. That is my personal observation.
Good. So so women especially, TB is very prominent in our country.
Yes.
And chronic PID, pelvic inflammatory disease, some of them are attributed to tuberculosis also.
Right.
Do you see infertility in such cases? Is it common in your practice, or chronic PID cases?
So I think it is very much prevalent because infection of the lower genital tract is something not very uncommon. Any woman after her married life has faced recurrent UTIs and PID infections. Sometimes it goes silent, sometimes they do not report, go to doctors, and it does the damage that it has done before anything is taken care of.
True.
Also tuberculosis, silent tuberculosis, many of like Indian patients are suffering from that. So it is a prominent cause of infertility in India. It can predominantly affect the tubes. So it can damage the tubes. You can have blocked tubes. And even if the tubes are not blocked, they may not be functioning properly. Also, the same infection can affect the uterus, the bed, the endometrium. So sometimes the endometrium gets affected, and the proper thick endometrium, which is required at the time of implantation, or proper vascularity does not happen. That's why the patient suffers from infertility and sometimes even from recurrent pregnancy losses.
Okay. So nice. Let us shift gears a little bit. I have seen the trend now that a lot of pregnancies are requiring luteal progesterone support. Previously, it was not much, but now I'm seeing a lot.
Yes.
And every pregnancy is very precious. So previously, it was like, now we are not successful, next time we'll be successful kind of attitude.
Yes.
Now, getting pregnant is very difficult.
Yeah.
And to maintain the pregnancy for 9 months is tough. So, what is your choice of progesterone? Okay. And what is your experience, or which patients require this? Even I've seen normal serum progesterone levels also, they have been supplemented with progesterone externally. So, just share a little light into this subject.
Right. So basically in our practice, there are only two hormones which are important. One is estrogen, one is progesterone. And as we read our physiology during our training days, a good ovulation produces good progesterone automatically in the body. So a good ovulatory phase leads to a good luteal phase.
Yes.
So many a times the low progesterone is because of the ovulatory defects only. So diminished ovarian reserves, disorders of ovulation, PCOS. These are the patients who also have a defective luteal phase and need some progesterone supplementation. Apart from that, whenever we are doing some treatment, like if we are giving some gonadotropin injections for conceiving, we are doing IUI, we are doing IVF, in all these patients, because these are stimulated cycles. So you need some progesterone to support the patient in the second half. Patients who are suffering from recurrent pregnancy loss, in many of them also the progesterone is deficient and they require progesterone support.
Definitely.
Now, which type of progesterone? Choosing the progesterone, it requires keeping into consideration so many factors, which may be related to the drug, the route of administration, the convenience of the patient, or if she has any history of allergies or personal preference to any particular drug, and also very importantly, cost. So cost has to be kept into mind. So commonly the preparations that we have oral preparations like dydrogesterone, we have micronized progesterone which can be taken either orally or vaginally.
Yes.
Then you have progesterone in the form of gels which can be inserted vaginally, and you have intramuscular progesterone.
Yes, true.
Now earlier more focus was on injections, but over time, because they are quite, whatever said and done, injections every day could be
They're
very
quite painful.
And
so, intramuscular, you have the big bore needle.
Yes. So I think the efficacy of gels and injections, it has been proven that it is equal. So gels could be easily used in place of injections.
Okay.
And also in like for IVF cases. And in non-IVF cases, we can do well with dydrogesterone oral or micronized progesterone.
Okay. So whatever literature I have read is dydrogesterone is obviously more powerful than micronized progesterone.
Yeah.
So dydrogesterone is used now, its usage has increased a lot. But there was a sudden, meta-analysis or a literature review.
Yeah.
It said it can cause some form of
malformations in the baby, and
yes.
There was a lot of negative publicity, and then the drug was withdrawn also.
Yes.
But after that, some other trials have come. Now the drug is back in a big way. We are using it routinely, and it ample evidence has come that it does not cause the anomalies in the baby.
So,
and also it has an immunological effect. The advantage of dydrogesterone is, apart from the progesterone part, it also has an immunosuppression. So it helps in people who have immunological problem in conceiving or in recurrent pregnancy losses.
No, all progesterones can cause little bit of
immunal effect. Yeah.
They reduce immunity. Otherwise, if they don't, then sperms cannot go.
Exactly.
They will be attacked very
Yes,
aggressively.
yes.
So what dosage of dydrogesterone do you usually prefer for? Is there any set that you can give as an example, like where do you give 20 mg or 10 mg or 30 mg?
So all the preparations are available these days.
Yes.
Like for example, if we are talking about IVF luteal support, usually we doctors in India, we do a little bit of over-progesterone usually.
Okay, yes.
So we are giving progesterone normally in at least two forms. So if it's like sometimes it is a vaginal gel plus a oral dydrogesterone. In that case, a single tablet of 10 milligram daily is sufficient.
Okay.
But if sometimes I am giving dydrogesterone alone as a support, then I would like to give at least 10 mg twice a day. And in patients who sometimes present with bleeding, like if they are on treatment and they are conceive and after that they present with
Threatened abortion
threatened
kind of.
abortion cases, in those cases we even give up to 4 tablet stat and then continue on 3 tablet TID and then maybe slowly taper down the doses.
And in this case, I think 4 tablet stat, some people even give medroxyprogesterone injections.
Yes, that also is given and it has good effect actually.
Yes, true. That's really great to know. So, apart from the progesterones, and now we come to, let us shift gears a little bit. OC pills usage in India is very less, whatever I have read and what I have seen in my practice. Mainly barrier methods are used.
Yes.
There are a lot of preparations of OC pills, and I feel that Dynogist combined pills, they have added advantage in PCOS also.
Yeah.
So what according to you is the best OC pill composition for Indian population?
So I think again here there are a lot of drugs, there are a lot of preparations, and it's difficult to say that which is the best. Again, there are some preparations which are available free of cost through the government sector, which are the classical preparations. They are also age old, they are good enough, they have good efficacy, suit most of the patient and are available at zero cost or very low cost. So they can do well. But like you said that there are newer preparations like Dynogest which can be used, and they have lesser side effects. They have other hormonal benefits which benefit patients with a higher testosterone level, PCOS. So those could be used in those patients. Whenever possible, we like to give the lowest possible doses of estrogen and progesterone to the patient. But as such, the acceptance of oral preparation, the acceptance of oral, it's very, very low. There are very few couples who would like to actually come down to using it.
True.
Because of probably the fear of steroid intake and the side effects and all also.
Yeah, true. So let us talk about recurrent pregnancy loss. Recurrent pregnancy loss is also a very major issue in our country.
Yes.
And recurrent pregnancy loss cases, we do use low molecular weight heparin.
Yes.
So kindly basically elaborate a little bit about what is this recurrent pregnancy loss and what are the common conditions in India and what is the line of management you do, particularly you do,
Right.
not the general one. What are, pro tip. You are a pro, we want a tip from you. So that is what we want.
Okay. So, sir, by definition, again, recurrent pregnancy loss will be any patient who suffered more than 2 losses consecutively. Now, the follow-up of this patient will depend mainly when the losses have happened, whether these are mostly first trimester losses, which is majority of the cases, or they are second trimester losses, because that's a totally different group of patients. When there's a patient with first trimester losses, when the patient comes in, we need to take a detailed history examination of the patient and also investigate the patient. The few things which are specifically in our mind at that time is to rule out that whether the patient has any hormonal issues like thyroid or diabetes, or the patient has any low progesterone issues, any history supporting that like short cycles or something like that. Also, in such cases, we need to rule out antiphospholipid antibody syndrome, because this is a big group of the patients which are suffering from this, and also beautifully, it is a treatable group of patients. So that's why investigating in this line and treating in this line is fruitful, because there's a treatment for it and patient responds very well to it.
True.
The third thing which is in your mind is genetic cause. That is, you want to do the genetic study for the couple, the husband and the wife, go into their previous like family tree and see if there's a problem over there. But again, if there's a problem there, that's not a treatable cause of the issue. And in second trimester losses, it's more of the cervical causes, cervical incompetence or infections and other problems which come into the role. Now, in patients with antiphospholipid antibody syndrome, we do some testing against some common antibodies. Many a times those tests come positive.
Okay.
Many a times those tests don't show any problem. But actually speaking, we are just checking the common antibodies. There could still be hundreds of other antibodies which we are not checking. So even if the investigation does not show antiphospholipid antibody syndrome, still in patients with first trimester losses, we somewhere want to give something for this group of patients, in which we initiate oral, like oral blood thinner like Ecosprin tablets or something. And also, as soon as the patient conceives and the cardiac activity comes in, we like to put the patient on low molecular weight heparin. And then we continue this heparin injections at least till the first trimester and sometimes even till the 8 months complete of the pregnancy.
Okay.
Yeah.
So almost till 1 month before EDD, you want to continue.
Yes. Yeah.
Low molecular weight heparin.
Because many of these patients later then have problems related to hypertension or IUGR or oligoamnios. So to cover all that perfusion issues, you like to continue it till 8 months.
I have seen doctors prescribing both aspirin and low molecular weight heparin.
Yeah.
I've seen doctors only prescribing low molecular weight heparin. So what is the right way, or what is the differentiation in this?
So what I am practicing and what usually I've seen other peers also practicing is that to start aspirin before pregnancy. So as soon as the patient starts planning, we put them on folic acid. We also put them on aspirin, which they continue during the planning period, and then they continue it after they conceive also.
Okay.
Heparin is to be initiated once the cardiac activity sets in.
Wonderful.
And then both of them go together, ideally till 8 months, or then depending on the case, if you decide or the patient wants to stop it earlier, then if she's doing well, then sometimes we stop it at 3 months also.
Have you seen any hit cases? Heparin induced?
Absolutely. I have had patients with even 8 miscarriages. She even visits me today, and I have done nothing for her except to add a heparin, and it worked beautifully for her. The 9th pregnancy went very well. So, and these are clear-cut cases. When they come to you, this is the thing, and this is what will work for her.
Okay.
Yeah. So I think that's one area which you enjoy because you could do something for the patient.
Okay. Wonderful.
Yeah.
So, small clarification. When I said hit, I meant heparin-induced thrombocytopenia, thrombocytosis.
Okay.
So, do you see, it is less with low molecular weight heparin, but do you see...
Rarely. I think all throughout I've just seen in one patient actually this happening. Sometimes I see patients with rashes. That is still more common. But actual thrombocytopenia, hardly, like in 20 years, I would have seen 1 or 2 patients who presented with this.
Wonderful.
Yeah.
Now, demystify. HMG, HCG, FSH. I have seen doctors, when I spoke to infertility experts, that they give it in physiological ratio. The FSH and HMG. So, demystify these 3 preparations in infertility. How do you use them?
Right.
In which case, what injection do you use? A basic about that.
So, I think in infertility practice, the knowledge about hormones and the drugs which are available, this is paramount. Like this is your base, you cannot work without it. You have to understand the drug first. Now, HMG is basically human menopausal gonadotropin. That is something which is derived from the urine of menopausal women.
Yes.
So, it has both. It has both FSH and LH. Recombinant FSH vis-a-vis has only, it's recombinantly, genetically engineered product, so it has pure FSH. It has zero LH in it. Then in between, you have some drugs these days which are highly purified HMGs, which have LH, but in a very less amount than classical HMG. So actually you have 3 groups of drugs, HMG and purified and the recombinant ones. Now, using the drug again depends on a lot of things.
Even HCG.
Even
One
HCG.
more HCG also.
HCG also.
I want you to...
Yeah, I will go into that as well. Now, these drugs, which drug you use, it depends, one, on the center preference. What you have been using, what works for you.
There is a wide disparity.
Yeah, everybody has their favorite.
Oh,
It
yes.
depends what works well for you. So sometimes it's a center preference also. Also, when I am running a center personally, I want something which is like, I'm procuring something and that's working well for everyone, So I don't want to have a like this drug for this person, this drug for that person. I should have something which works for majority of the people. The convenience, the drug is coming and it's getting used and you are refreshing it. So that is also one aspect. Thirdly is the cost. So as you go into recombinant, the cost increases drastically. Not everybody can afford it because sometimes you have patients to whom you need to give a low cost IVF also. And then there are medical conditions, So there are some condition in which you do require some amount of LH activity to stimulate the patient. They will not get stimulated with recombinant alone.
Okay.
So like
FSH alone will
not work for them. Like especially patients with poor ovarian reserve, they do require some amount of LH stimulation
support.
also. Now LH could be given in any form, either as a combination in HMG, or nowadays even HCG is given as a LH surrogate, that it will go in the body and it will produce LH, and that's how it will improve the quality and number of oocytes. Also, you have recombinant LH available these days, which could be given. But then again, when we go into recombinant LH adding, then it becomes very costly for the patient. So I think all these factors are taken into consideration. Mostly we devise a protocol for our center and then we work accordingly. So that ways, personally, I think HMG in a purified form works well for me. It's a medium, in between solution. It has a little LH activity, so it'll work for all the patients. It'll work for those also who require a little bit of LH. Cost-wise also, it becomes medium. Then there are patients who require who are ready to afford. And in those patients, we start with FSH. And so that can be individualized on a case-to-case basis.
So you use both of them?
Both of them,
depending upon the patient condition.
Yeah.
Wonderful. So you use ANTAC protocol only,
yes.
right? So what is the trigger that you use for ANTAC protocol?
So actually in infertility, classically you can say there are only two complications which could happen majorly.
OHSS.
One is OHSS, one is multiple pregnancy. So earlier there used to be a lot of cases with OHSS. Now most of the clinics, they want to be OHSS free and they don't want to have any complications, because first of all, see, patient has come to us for infertility. She is not a sick person. So our job is not to make her sick.
More sick.
Even if we don't give her the baby, she should remain healthy. So we want to give her a OHSS free treatment. In that ways, ANTAG is very helpful, because in that you could give a GnRH agonist trigger. Because in hyperstimulation, the culprit is HCG, whether internal HCG or external HCG. So if you're not giving a HCG, hyperstimulation classically will not happen. So that ways we use GnRH agonist trigger. But of course, when you're giving GnRH agonist trigger, you could not do a transfer in the same cycle. If for any reason we are planning a transfer in the same cycle, then we prefer to give a HCG trigger.
HCG trigger.
Yeah.
Okay, wonderful. So what kind of trigger do you use for ANTAC protocol in your practice?
Right, sir. So like now we are doing antagonist protocols, and in infertility practice, there are two conditions which we consider as complications. One is hyperstimulation, one is multiple pregnancy. So
OHSS.
mainly OHSS. So basically what we want to avert is OHSS.
Absolutely.
For that purpose, we like to give an agonist trigger, and we avoid giving HCG triggers. And because in OHSS, the culprit is HCG. So if you're not giving HCG, classically OHSS will not happen. But when we are giving a agonist trigger, that time we cannot plan a fresh transfer. So if there's a patient where you're planning a transfer in the same cycle, then you prefer to give a HCG trigger.
Okay.
Yeah.
Wonderful. One condition which a lot of awareness has increased, especially we are getting a lot of actresses coming left, right and center and saying that I have this condition, I've suffered a lot from this, that is endometriosis.
Right.
So how common in your practice is endometriosis? I've seen women with very diffuse symptoms like some shoulder pain. Some people come with unexplained back pain.
Right.
So how common is this condition in your practice, and how do you diagnose it and manage it?
Right. So endometriosis, classically they say the incidence is 10 to 15%. But Asian population is more predisposed to it. So that is a genetic predisposition. So I think the incidence is more in our people. Now, in endometriosis, the symptom is pain. The main
Absolutely.
symptom is pain.
Only
Pain
pain.
anywhere. So it
Anywhere.
could be abdominal pain, it could be dyspareunia, that is pain during sexual contact, it could be pain during menses, dysmenorrhea, or sometimes vague pain. So
Is it classically cyclical pain?
classically,
Anywhere in the body, is it cyclical pain only?
yeah, so according to the physiology, it should be a cyclical pain. But sometimes in advanced cases, and depending where the disease is in the body, sometimes the pain can linger on throughout the month also.
Okay.
So, of course, endometriosis, it has grades, grade 1, 2, 3, 4 and all. So, if the patient has like cyst, if she has endometriomas, that is where you can pick up the patient on normal ultrasound, and
Yes.
so you will be able to see her endometrioma, you will know that she's endometriosis. Actually, through a good history taking also, you will have it in your mind that she might have endometriosis.
Okay.
So before you even take up the patient for examination, it is there on your back of your mind. So that is one group of patients who are presenting with pain. And then on ultrasound, you see a cyst or an endometrioma, and you know that she's endometriosis, you investigate it further. In many cases, if it is early, if it is grade 1, 2, until now the cysts have not
In
formed.
ultrasound, do you really see the size of the lesion increasing or decreasing with the cycle?
Yeah, you can make it out, sir. It
can
is
make
there.
it
Like
out.
it is very classical actually. And also, like sometimes in early cases, there'll be no endometrioma. You cannot make it out. That,
True.
but in that cases, you will see some pelvic tenderness, deep pelvic tenderness when you're doing a transvaginal ultrasound. Though you cannot say it's endometriosis, it could also be because of PID or other cases. But it puts a suspicion in your mind. The final diagnostic procedure to diagnose endometriosis, to label endometriosis or to grade it is laparoscopy. So when you do laparoscopy, then only you can label the patient as endometriosis, you can grade the disease, stage the disease, and accordingly you can decide the management of the patient.
I think we should come up with some kind of a marker which, like a PET, PET, we have this radioactive glucose which goes and lights up the tumor
malignancy.
cells. I
Yes.
think we should come up with a marker which will go in and it will light up the endometrial
It's a
tissue.
beautiful thought, sir. Till now, all the markers are non-specific, but it also react in many other conditions. So we don't have a specific
do you
marker.
give GnRH agonist, especially leuprolide, for this kind of condition? Or do you regularly give it, or for not a very grade 1 endometriosis, you prefer something else?
So, like if we just talk about endometriosis, these patients might be coming to you mainly for two conditions. Either she's coming to you because she has pain, or she's coming to you because she has infertility. Now, if she's coming for pain, then the idea is suppression, hormonal suppression. Whether you do it in any form, you can you could use oral preparation, you can use contraceptive pills, you can use the newer drugs which are coming in the market like Dynogest and other drugs. Now, even you have the elagolix tablets and all,
Elagolix has
which are
come.
there.
It's an oral
Oral
antagonist.
which is being used, or you could use a GnRH analog. All of them work on the
How
same.
is the data on that? It's a very new molecule. So
The data is supportive, and we have started using it also, and it is working well.
because I've seen its uptake go like this, and now it is coming down.
So, sir, actually, I think it could be like said, it is a dream of any IVF doctor. If I could do IVF without injections,
Yes.
there could be nothing better. Because what does my patient not want? She does not want injections, So half of the problem is solved now. You have an antagonist. Now remaining is gonadotropins. So the day you have oral gonadotropins, we can do the whole treatment even without a single injection.
Yes.
So that's the beauty of how science works, that, things are coming up. And we were discussing like how we could use
Leuprolide.
So leuprolide in those conditions, it is given like for suppression and to control the disease state and for the pain management and to shrink the size of the lesions. Also post-operatively, when we are operating the patient, the idea is to remove as much of the disease as possible.
Okay.
But sometimes it is not possible to remove all the disease. It is not, because sometimes it may be deep-seated and some amount of it remains. To suppress that part, also post-surgically, we give injections for 2 to 3 months so that the complete disease can be taken care of.
This kind of a thought always nagged at me. After giving leuprolide, there is suppression of your estrogen, progesterone, everything, luteinizing hormone, FSH, everything suppresses. How long will the endometrial cells last? When will they die? In the endometriosis, The cells, how long they can survive without the stimulation of the...
So basically, they are under suppression. The moment you stop the drug, and the cells again receive estrogen and progesterone,
Okay.
they'll start proliferating again.
They'll again.
Now the problem is that this drug, also because it causes bone loss and all, you cannot go on giving the injections forever. So after some time, you have to give a break. Maybe you can give it continuously for 3 months, maximum 6 months.
Yes.
So whenever you will stop it,
There are longer preparations, especially for sex change processes. There are longer preparations.
you could give longer preparation, but you have to see that what side effects would
because endometrial tissue sheds with every cycle.
Yeah.
So I always wanted to ask an expert, how long will endometrial cells survive outside their uterus without the stimulation of sex hormones? Will they go into apoptosis and they die, or...
I think, sir, maybe those cells will die, but if the pathogenesis is on, such other cells will keep coming up.
Okay.
So the disease, because it's a progressive disease, no?
Yes.
So the process is going on in the body. It'll never stop till she has menses.
Okay. Since he has menses or menopause?
Till she has menopause.
Okay.
Yeah, this process will be going on in her body forever.
Wonderful. Excellent. Now, let's come to a topic which is very dear to me. I've lost patients. It is a very simple thing, but unfortunately our country is like the most notorious in this aspect. That is iron deficiency anemia.
Truly.
So iron deficiency anemia, we know that almost as for National Family Health Survey 5, 57% of women in reproductive age group are actually iron deficient.
True.
So your thoughts, how do you manage iron deficiency? Do you prefer oral or do you go for the newer injectables? Or what is your thought process on this? Do you feel that oral still has a role, especially with powerful injectables like ferric carboxymaltose? What is your thoughts on this?
So basically, because maybe I'm dealing with a more of a urban population, I will not say that I see very severely anemic patients so commonly. Like most of the women, they are from decent family backgrounds and like not the kind that you would see in a rural population, not that much incidence we are seeing here. So for me, whenever the patient is coming to me as an antenatal or anything, diet counseling starts from the first day.
Yes.
So we are insisting that she needs to take oral iron-rich food and proteins and everything you are telling her. So first of all is prevention. So you have to make them, mind prepared that they should be taking orally adequately in the form of diet. Now, as far as giving the supplementation, for routine, you are giving oral preparations only.
What oral preparation do you prefer? You have a patient who is going to deliver in the next 3 months with low iron. So do you prefer oral or you want to correct it with injectable?
So, and what would be a hemoglobin level?
Well, let us say 8.
And we have 3 months to go.
Yeah, we have 3 months to go.
So I would prefer oral.
Oral only?
Yes.
Not injectable?
No. Yeah, unless the patient is not able to tolerate the drug, she's not compliant, or there are some absorption issues that I feel. If I, she's tolerating the drug, I would still prefer to step up the dose and use oral preparation. If maybe you will say ki less than 7 or if there's less than 1 month to delivery, I have no other option. I don't have any time because anything will need at least 3 to 4 weeks to work. Then only I would like to use injectable preparation.
So 1 month before you would prefer injectable
preparation.
Fine, good enough. Okay. Nutrition plays a very important part in getting conceived, or even for a young woman who is just attained her menses. And apart from nutrition, vaccination is very important. There is one vaccine that I want you to elaborate and tell our viewers the importance of nutrition, the importance of this one vaccine or other vaccines that an adolescent girl who has just attained her menses, just attained puberty.
Right.
So from there to the teenage, what in nutrition wise and what are the vaccinations which are very important? Please.
Right. So I think nutrition is important for everyone, but more important maybe for the young girls. especially because they have this additional problem of menstruation. So they are going to be menstruating, they are undergoing body changes, they'll be losing blood every month. So over and above boys, girls need extra nutrition, I would say. Also, there is a problem of mindset, maybe not in urban India, but yes, still in rural India, where maybe the females are not given so much preference food wise.
Absolutely.
So considering all that, I think there has to be a mind change. People have to be more aware of what a young girl's nutrition should be like. Also, sometimes these days parents are very very aware about nutrition, but children are becoming very picky and choosy about food. So even if everything is available, everything is being given to them, they don't want to take it. So you have to educate the children about the importance of nutrition, what changes are going on in their body, or if they are not eating food in a particular way, what are the problems that could come up.
Yes.
We all know that the problem of junk food, how it is increasing the hormonal issues, how it's increasing PCOS, how the incidence of endometriosis and other diseases are increasing, which are related to lifestyle problems.
True.
So overall, initiating a healthy lifestyle change, just like Modi ji is promoting a healthy lifestyle change, we have to educate even the young population towards a healthy lifestyle.
Wonderful.
This includes a good daily routine, a good getting up time, a good sleep time, adequate sleep, good physical routine. Everybody should be engaging at least in 1 hour of physical activity per day. Many of the kids these days, they don't have any physical activity. The screens are taking most of their time.
True.
So some kind of physical activity which promotes their muscle growth. Also mentally, it makes them stronger and, increases their mental levels. And then comes diet. So diet should be healthy, balanced, mixed balanced diet, which includes all the nutrients, the calorie requirements of the age group. Not only undernutrition, even overnutrition is a problem. Obesity is becoming a big problem these days. So that has to be checked. Specifically, these girls, because they'll start menstruation, they require extra iron intake in diet. So iron-rich foods have to be promoted for these people. We know to produce hemoglobin, we just don't need iron. We also need proteins. We need vitamin B12. We need vitamin C. So everything has to be taken. Folic acid, everything. So diet has to be wholesome. Then only it will take care of the proper hematopoiesis. So diet has to be instilled in their mind, in the parents' mind, and it has to be followed on a day-to-day basis.
Wonderful.
Also, if somewhere we feel that maybe diet will not suffice, a basic kind of a supplementation could also be added.
Yes.
If the children are not able to take, sometimes they have schools, they have classes, they're not able to manage. So some kind of supplementation can also be added to these
Wonderful.
children. Also, vitamin D is deficient in most of us. So that should be given to the kids. Protein should be given in an adequate amount. Now, coming to the other question that you asked me regarding vaccination. So
yes.
apart from all the pediatric vaccinations which are given to children, specifically for girls and even nowadays for boys also, the HPV vaccine, it has to be given. Now it is in the government schedule. It is recommended for everyone. It has to be taken. It's a mandatory vaccine.
Okay.
And the vaccination can start from 9 years of age. It does not matter whether you have started your menstruation or not. You can start the vaccination at 9 years of age. If you're taking it before 15 years of age, you just require to take 2 doses of the vaccine, 6 months apart. If you are taking it after 15 years of age, you have to take 3 doses.
3 doses.
And currently the recommendation is that the vaccination could be taken till 45 years of age, but taken sooner, it has better effect.
Better protection.
So, and the drug as such, the injection, there are enough studies. There are not many major side effects or do's or don'ts. It does not matter which day of the period you're going.
You prefer the quadrivalent one?
Quadrivalent one. So that vaccination we have available, we are recommending to the patients. Ideally, as per schedule, everybody should be taking it.
Wonderful.
Yeah.
So today I learned a lot from you. I got great insights from you. Many of my long-standing, doubts, to put it very mildly, have been cleared. Thank you very much for coming and sharing your clinical insights. I wish you all the best. I wish you that you give more mothers or more couples the bliss of motherhood. Thank you very much, ma'am.
Sir, you've been very kind and generous. I think more than me telling you anything, it was a very interesting one-to-one discussion that I had with you. I thoroughly enjoyed this conversation. And thank you so much for your blessings, because that is what I seek. My job is to give what the patients comes to me for, and motherhood. It's a dream of every woman, and I think it should be fulfilled. Thank you so much.